So we made a video about infected total joints.
Yep.
But we didn't really tell you what to do about it.
No, we talked about how to diagnose it.
So now we're going to talk to you about how to treat an infected total joint. We call it a PJI, or a prosthetic joint infection. Could be an infected total knee.
Yep.
Infected total hip, shoulder, elbow.
Anything. And unfortunately, this is a very serious problem, but there is a wide spectrum of treatment based on a bunch of factors: the location, the how long it's been there, what type of bacteria is there, and what treatments have been tried so far. So we're going to start at the very, very beginning and end at the end, which is unfortunately some really not very great treatment options.
Okay, well, don't give it away.
I won't give it away. I'll keep you a cliffhanger.
All right. So you've been diagnosed with a prosthetic joint infection.
Yes.
You watched our previous video that talks to you about the signs and symptoms. Now, the mainstay of treatment depends on the acuity of the infection.
Right.
So what I'm trying to say is, if it's an acute infection, so within the first 2, 3, or 4 weeks of having that joint implanted, or within the first 2 or 3 or 4 weeks of the infection happening.
Right. So there's two different types of acuity: the index procedure and the symptoms.
Right.
Got
so
it.
either you just had the joint done and it's within 2 or 3 weeks of that, or you had it done a few years ago, but the infection just came on 2 or 3 weeks ago.
Right.
It's an acute infection. There's nothing cute about it.
There's nothing. It's acute.
But it's an acute infection.
Right.
So the treatment for that is probably best case scenario.
Right.
And that is, we go in for an irrigation and debridement.
Yep.
Maybe change the plastic liner or 1 or 2 easily changed parts.
Right.
Followed with some IV antibiotics.
Okay, so this is typically done in a general or a spinal anesthetic. You open up the wound, use a bunch of fancy irrigation products to try to reduce the bacterial load that's there from the infection. We assess the stability of the components at that time, swap out any parts that are easily swapped out, close you up. Antibiotics. And the antibiotics would be a combination of intravenous and or oral antibiotics, depending on the type of bacteria. And usually we commission our infectious disease people to help us and help guide that decision.
Right. And this is an evolving science. We are learning more and more about it every day. And so the type of antibiotic chosen, the duration of the antibiotic chosen, and whether or not the infectious disease doctors want to use an antibiotic, those are all things that are changing. So when you watch this video, there may have been some subtle changes.
For sure.
But this is sort of the way we treat them right now.
Okay.
The other thing I want to distinguish between is, this is a prosthetic joint infection we're talking about. We're not talking about that superficial infection where the wound is red. That's just like a cellulitis or a superficial wound infection that's often treated successfully with a topical antibiotic and some oral antibiotics.
Yep.
Occasionally IV antibiotics if the infection is a large area.
The purpose being to try to prevent a deep infection.
Yeah, and to treat that superficial infection. So the infection has not gone deep. And sometimes it's really tough to determine.
Very hard.
Is it a superficial infection or is it a deep infection?
Right.
That can be tricky to determine. However, if it is a superficial infection, that does not need a surgical intervention.
Okay, and so after you do the irrigation and debridement, how long are you typically on antibiotics for?
Usually it's at least 6 weeks.
Okay, so at least 6 weeks, and sometimes it's 6 weeks of IV and then 6 weeks of oral. Infectious disease is going to help guide that with a host of different measures. So clinically, how you're doing, potentially some blood work that we would follow along to see if that's improving. However, early on, it's all typically elevated, and then they would make a decision. So say you finish your course of antibiotics, then what happens?
And the choice of antibiotics and the duration of antibiotics, in addition to those factors that you mentioned, also depends on which bacteria it is that is causing the infection.
And we mentioned that, and that will be determined either preoperatively with an aspiration or sending samples during the procedure to the microbiology lab to grow some bacteria.
Okay. So what was your question again?
So you finish your antibiotic course. Now what? What do you do now? Is it just antibiotics, then you're done, everybody's good?
Then you need some follow-up to make sure that the infection is cured. So there will be a period of follow-up after that.
Right.
And sometimes blood work to assess if the inflammatory markers in your blood have come down.
Right.
Inflammatory, not like this video is right now. Inflammatory, like markers that indicate that there's some sort of inflammatory process. And the 3 main things we measure are the CBC to look for a white blood cell count, which indicates infection, the CRP, which is elevated with infection,
And then we'll slowly go down.
and the ESR, which is elevated with inflammation, which can be caused by infection.
Okay, so what would you say the success rate, like taking all comers, is of irrigation and debridement?
That's a good question. Again, that depends on the host, which is you, and the bacteria, which is the thing that's infecting you.
Okay.
But I would say, usually we can get at least 80% success rate with that.
Yeah, I'd agree, depending on the timing for sure. Okay, so say we think, you know what, this has maybe been around a little bit too long, or the implant's too old, or whatever, and you decide irrigation debridement is either not right, or maybe even you've tried irrigation debridement and that did not work. What is the next step in the treatment algorithm?
Quiz question for the viewers who have watched our videos before. Why do you think, if the infection's been there for longer than a few weeks, a washout or simple antibiotics won't work?
Leave a comment if you think you know the answer to that.
Yeah, and check one of our older videos.
Yes.
So it's not going to work. So
Yeah.
you're now in the situation where you need to remove parts.
Right. And we've talked about this before, where bacteria leave substances on the metal implants that can't necessarily be penetrated or cured by antibiotics, like a biofilm. So sometimes, whether it's an artificial joint or even other infected type hardware, all of the hardware has to be taken out.
Glycocalyx, we call
Yes.
that fancy that fancy word. I say it's like having a splinter. You can have a splinter in there. If it's infected, you can do anything you want to do to get rid of it, but the only thing that's going to cure it is to remove the splinter.
Yeah.
So I think of the implant like a big splinter that's infected.
It's a big splinter.
So now, can we take it out and put in a new one right away, or do we do it in a staged fashion? That's the
Yes.
question. Right.
Yes, you can do both. So those are both options depending on, again, a host of reasons: surgeon preference, bacteria, suitability of the candidate, whether or not they can tolerate two procedures. There's a bunch of different things. So let's talk about the one stage.
So a one-stage revision where would be you go in one setting, you remove the hardware that's in there, all the hardware that's in there, and you replace it with new hardware.
Okay, so before we go further, is this something that's easy to do or something that's hard to do?
It depends.
I think it's mostly hard.
Do you think?
I do. Getting it out of the bone, I'd say generally it's.
Yeah.
I think the average person would not be able to appreciate how difficult it is. It requires often like a hammer and an osteotome, which is like an orthopedic chisel, to remove the contact surface of the bone and the implant. So
It's difficult, but sometimes it's more difficult than others.
okay, fair.
For example, if the infection's been there a long time, sometimes the implant is a bit loose.
Right.
And now the bacteria has done your job for you by loosening it up. Okay. It's kind of like a keto where you use your opponent's momentum against them.
Right, and then to launch them.
Yeah. So the bacteria has helped you in that sense. However, if you have something like an uncemented hip stem that's been in there for a long time,
Right.
that can be very difficult to remove.
Because your body literally has grown bone onto the surface of that implant, and you have to break that bond.
Yeah. And there is some research going into the possibility of leaving those well-grown implants in and doing a thorough cleaning job around them. That is sort of being explored now. It's not the standard of care yet, I don't think, but some people do that sometimes.
And there are some newer commercial products that help break down that glycocalyx. that we talked about.
Yes. But I mean, traditionally, it's
Yeah.
remove everything and put in a new implant.
Right. And so what is the concern about doing this all at the same time, like doing the one stage versus the two stage that we'll talk about in a
The
second?
main concern is that the success rate is not quite as high as a two-stage revision. A two-stage revision is where you go in, remove the infected implant, put in a temporary one with some cement that has antibiotics in it,
Okay.
take some IV antibiotics for a while, and then go in and do the second stage, which is the definitive.
Right, which is like often 3 months later, and
Yeah.
then you test it again,
Yes.
stop the antibiotics for a little while, make sure that the infection's gone before you go on to the
Yeah.
definitive procedure.
That's a two-stage procedure, and the success rate of the two-stage procedure is a little bit higher than the success rate of the single-stage procedure.
Right.
However, it carries with it more morbidity.
Sure.
Right.
Two big
Morbidity-
operations.
Yeah. Morbidity just means bad stuff.
Right. Okay. So what would you say the success rate of the one stage and the two stage?
Again, depends on the host, depends on the infection, depends how long it's been there. I'd say, a one stage in certain settings can give you like a 60 to 80% success rate. A two stage can give you something like an 80 to 95% success rate.
Agreed.
Those are ballpark numbers.
With the one stage and the two stage, are you still having IV or oral antibiotics after?
That is traditionally what we do. There are some infectious disease specialists who would say, well, if you took everything out and you cleaned it out good, you don't need antibiotics after. But I would say that the majority of the orthopedic surgeons polled would say, yeah, no, you need some kind of antibiotics after.
Agreed. We definitely would agree antibiotics afterwards. So now you're done the antibiotics. How do you follow it long term?
I think you follow it long term at that point, just like you follow any revision.
Right.
Be vigilant.
Yep.
The patient should be vigilant about any of those signs. I think I'm getting an infection again, because
Right.
recurrence does happen.
Unfortunately, yes.
Recurrence can happen just because it happens again because of the reason it happened the first time, or maybe there was some bacteria that's still in there that was dormant,
Yeah.
that is acting up again later. So you just have to be careful and keep an eye out for these signs and symptoms that we talked about in our other videos.
And if that does happen, unfortunately, if you get another deep infection, you start the process all over. Okay, so say you did all that stuff, you did the irrigation debridement, you did the 1 or the 2 stage, and you still have an infection. You've tried it maybe even multiple times, and you can't cure the infection. Are there any unfortunate salvage type procedures that say, okay, we can't cure this, or this is where we're stopping?
Yeah. So if it goes on and it's just not curable after so many tries,
Yep.
and you repeated your 2-stage, you tried and tried again, then we look at things like excisional arthroplasty. For example, in a hip, we would just remove the hip.
Right.
Okay. Remove the implant, and you don't have a hip anymore.
Okay, so can you walk on that?
You can walk on that. You know what I mean? That's an old procedure that used to be done for arthritis before we had implants.
It's actually called a girdle stone, which kind of is like, it's a cool name, but it's not a cool thing to have.
Yeah, it's not. But apparently, the older literature said a third of the time you do fine, a third of the time you can walk with some discomfort, and a third of the time you're just not doing well at all.
Right.
That's sort of the old data for that. If it's a knee situation, then we talk about fusion.
Right.
Excising the knee joint and fusing it so you just can't bend your knee anymore.
Which is not a guarantee in the setting of infection. It's actually difficult to obtain a fusion potentially.
No.
Yeah.
And then the place where nobody wants to go and we don't want to talk about, an amputation.
Yeah.
And a non-curable infected knee replacement, sometimes an above knee amputation is the only thing that'll cure it.
Right, and to the point where at least now we have options. Back in the day when total joint replacements first started, John Charnley used to talk about the amputation test because one of these types of procedures was a very real potential outcome. So they would say, listen, unless your joint is bad enough that you would rather have it amputated than have an artificial joint put in, maybe you shouldn't have it done. So that was what he called the amputation test. Thankfully, we're way beyond that.
That's extreme.
It is extreme, but that was a real possibility for them. And then I'd say the last one that we didn't talk about is potentially something called antibiotic suppression or chronic suppression, where you'd be on lifelong antibiotics that would not cure the infection, but they would be able to suppress them enough that you would be able to live with minimal pain and dysfunction.
And that carries with it all the side effects and risks of being on antibiotics for a long term.
Right. It's not a very happy topic.
No, it's not happy. I mean, it is happy in the sense that it is curable.
Yes.
It is treatable. There is a good chance of cure and good chance of treatment. However, there is a chance that you can't cure it.
Agreed.
Leave some comments if you've had this happen to you, if you
Yes.
have, or if you know someone.
Yeah.
Any hopefully happy stories you can share with others who are reading the comments that might make them feel better if this is happening to them right now.
Now you know all about treating infected total joint replacements. And if you like this video, please like and subscribe to our channel.
And remember, you are in charge of your own health.
We'll see you next time.